Extended IPOM plus. A 45-year female presented with M2 and M3 recurrent hernia and was associated with the diverication of recti. She underwent an IPOM plus. One can see the M2 M3 defect with the previous scar of a surgery as well as the diverication of recti. Upon entry and pneumoperitoneum, one can see there are clearly two defects in the M2 M3 region. For this, our approach was leg split position, and what we are standing is in between the legs, and below upwards we are dissecting because there was a diverication in the supraumbilical region below the sternum. So we can see the ridge of a previously placed mesh, and gradually the dissection is done to take off all the fat in the preperitoneal region, and recti are exposed. Small fast current bus is used in order to completely delineate the hernia margins. One can now see the clear demarcation of the hernia margins. Furthermore, the dissection is extended cranially till we see the convergence of rectus muscle. One can appreciate the diverication over here. She was a relatively, obese female with a BMI of around 32. So we decided to fix the diverication also with the IPOM approach only. And what we are doing over here is we are taking a couple of bites quite cranial to the defect and starting from near the Zifi area from below upwards we are doing suturing, and gradually we are progressing from Zifi area towards the umbilical area for the closure of defect as well as the simultaneous closure of diverication and approximation of the diverication. In our practice, we generally try and take initial multiple sutures so that you don't need to pull much. Once we place all the sutures, then we reduce the intra-abdominal pressure and followed by gentle compression on the abdominal side and pulling of all the sutures together. This avoids the pressure on one suture at a time. And then further again, once all the thread is pulled, we progress our suturing further. Gradually the suturing is progressed. Couple of bites are taken at the site of large hernia sacs also in order to obliterate the defect early. Choice of suture material is a barbed suture, most likely number 1, so that gives a good strength as well as good holding also, and necessary for the assistant is warranted, and one can continue with the suturing with only 2 hands and it will still hold the suture for a longer period of time. These are the delayed absorbable sutures. So now we can see that the entire defect is approximated along with the rectus muscle, and further tightening is done. Observation of the closure of the entire defect is done. Inspection is done thoroughly so that all the linea both the side is approximately, followed by a dual layer mesh placement with the transfacial 2 sutures and fixation with the absorbable tackar is done with the outer and inner grounding in a standard fashion. So here we are using 15 by 20 centimeter size mesh to cover both the defects. The second case is a little different. A patient underwent multiple surgeries and previous IPOM plus as well, followed by mesh infection and then removal of mesh, and then he had a recurrence of hernia again, and it was a difficult and challenging case with adhesions all around. Once the adhesiolysis was done, in a similar fashion, we decided that we will be reinforcing the entire both side recti muscles before putting the mesh. So the suturing is again started typically further and beyond the level of defect. One can now gradually see as we progress toward the suturing that there is a significant gap between the two recti. However, that was not a part of hernia sac. Till now we have not encountered the hernia area, but the muscles are way away from each other, and there is a significant diverication like separation of muscles. However, it was not a virgin abdomen, but patient had significant fibrosis in between, but there was no muscle left in between. So we decided to suture it from beyond the point of gapping, and then gradually we sutured, we tightened the suture, and as we progressively reach near to our defect, the pneumoperitoneal pressure is reduced. Now one can see the large hernia sac, multiloculated sac is seen. So we started suturing quite a significant distance from the hernia original site, and we believe that that gives a good strength to the midline whenever we are doing repair of this variety of either recurrent hernias or the hernia which are happening during the diverication of recti who are carrying a very high rate of failure. So of late we are doing this particular variety of long suturing and covering the entire defect with the large size 15 by 20 or maybe even larger size absorbable, I mean dual layer mesh. So here one can see that we are currently doing suturing from head end, and we have progressed from hypogastric region to the epigastric region. Now it was the time to switch the suturing from below. So the surgeon is standing in between the legs, and one can see now that the defect was in the epigastric region. We again start suturing with another barbed suture, typically beyond the defect area, to give a proper strength to the approximation that is going to happen. And the suturing is progressed from cranial to caudal end over here, and in the midline both the sutures will meet each other. Once all the sutures are placed, gradually one by one suture is then tightened. Intra-abdominal pressure is reduced to around 10 so that the rectus muscle can be easily approximated with each other. And these defects are not more than 3 to 4 centimeter in size. However, the hernia size was quite big, but the adjoining area was not good and healthy enough. So we decided that we will be suturing from head end to the well up to the hypogastric region to the toe end of the abdomen. And in previous case also there was a significant diverication, so we sutured entire diverication and then reinforced the entire diverication with the help of the barb suture, followed by dual layer mesh which has been now placed. And typically we use two transfacial sutures in the midline so that the mesh remains over there. To hold the mesh, we always use the absorbable tackar, and the suture that is used for transfacial fixation is always also a polydioxanone, so that that is also absorbed over a period of time. And Typically, the mesh is fixed outer layer first, followed by the inner crowning, and complete fixation of mesh is done. Here also we are using a 15 by 20 centimeter mesh, and the final 12-meter port is also closed transfacially. This is the post-operative result of a patient. Thank you.